Hi, my name's Ruth Astbury, a women's health champion, resilience and wellbeing coach. I specialise in perimenopause and menopause, and I also run a corporate wellbeing business. And in my spare time, I like to take part in endurance sports, swimming, running, cycling, and avoiding leaks.
I'm Lizzie, a clinical specialist physio in pelvic health. I run an NHS clinic and a private practice called the Pelvic Physios. I love what I do and I love all the patients that I work with, and I have first-hand experience. I always forget about this bit. I am the proud owner of my very own vaginal prolapse.
Marvellous. And I always say, oh, yeah. Well done.
And I was going to say there, yeah.
And welcome to
Beat that.
I Peed My Pants podcast that's here to break the silence, smash the stigma, and get real about female incontinence and pelvic floor. And this evening, listeners, ladies, we have a very special guest, one of our first special guests, Claire Phipps, from a GP and British Menopause Society Council member and specialist in the menopause. Claire, welcome. Thank you for joining us.
Thank you both. Thanks for having me.
It's lovely. It's lovely to hear. So this evening, viewers, listeners, we are going to do a little bit of a background into Claire's background and how she has ended up being an influential figure on the British Menopause Society Council. And we're also going to dig a bit deeper into GSM. So Claire, can you please tell us a little bit about about your career, where you started out, and what sparked your interest in women's health and specifically the menopause?
Yeah, thank you guys. Thanks for having me. I mean, essentially, I'm a GP, I'm based in London, and as many GPs know, you have to go through a kind of a series of medical rotations before you get to GP training, and then you get to GP training, and it's a bit of hit and miss about what sort of training you might get, i.e. what specialties might you train in. It's not a standardized sort of routine, if you like. So by the time I got to my GP placement, I really didn't know very much about menopause. Yet as a female GP trainee at the time, of course, I was seeing a lot of women, because women obviously more often than not tend to go to women GPs. And it was around the time, and it was still around the time, that we were really scared of hormone replacement therapy. The WHI study was still kind of in the background. We were still all very scared about starting HRT, and I wouldn't really start HRT or even think about having those discussions very often. So quickly it became very obvious that I needed to know more. So that was really what sort of sparked my interest. It was the need to know more, but also the fact that I was seeing lots and lots of women coming through who just were now, in hindsight, at a perimenopausal age, and possibly even a premature menopause, that were just not being treated properly. So I did lots of women's health courses, trained with the British Menopause Society, then did some further training with the British Menopause Society before I became a menopause specialist. And that's really sort of a very brief overview of how I got to where I am now.
So you didn't. So when you were studying to be a GP, then what did you didn't cover the menopause on your course as a GP?
So I was one of the very, very lucky ones in that my GP trainer was the menopause specialist in my surgery that I was training in. Now that is rare. That's the exception, not the rule. So I was lucky. I shouldn't have been lucky. Luck shouldn't come into it. But I was very aware of menopause and HRT and the holistic management of menopause very early on. How to treat it was obviously a narrow window in my learning, hence the kind of further knowledge I did. But we have to remember, at the time of my training, menopause wasn't part of medical training. I didn't have a day on menopause at all. I remember having, obviously we go through endocrinology, we learn about periods, we learn about contraception, we learn about not getting pregnant, IVF, but never was post-reproductive health on the agenda. So it was really, and I know that's changing, and I trained a while ago, but it wasn't mentioned, no.
How many years ago was that, if you don't mind me asking? When did you qualify?
So I would have been in medical school, God, about 20 years ago now.
20 years ago. It's not. So now that's staggering, isn't it? And was the that's
not
really
that long ago though. It's not. I don't find like it is staggering, but it's not that long ago. And you think, God, that's,
no, it's not that long ago.
Do
But
they include it now, don't they?
They include it now, but it's also
Yeah.
very it's still not standardized. So
Oh, right.
we still
Okay.
don't have, like, we know that you've got to do cardiology, we know that you've got to cover or biochemistry, for example, but actually menopause, I don't think that's still standardized. It's getting better. It is
Yeah.
getting better, but I still think there's more that we need to do.
So, for example, this has just popped into my head now. So I've agreed to do some GP training. We've got like a little slot, and I'm doing it with my bestie in the continence team. She's a so. For example, so in your sort of opinion, I know obviously it's different, but for the GP trainees, me doing a session on, as long as nobody else is doing it on GSM, would actually be quite useful, wouldn't it? Because that's what I send loads of my patients back to GPs going, right, with the greatest respect, can I have a look at this? Could you possibly consider prescribing that? So that could be quite useful, couldn't it?
Absolutely. And I think the more that we do it as kind of an MDT approach, so a multidisciplinary approach, and it shouldn't just be about the GPs, it should be about practice nurses, it should be about women's health physios. It should be about, if you go and see a rheumatologist, they know about GSM. So actually training our GP trainees, training everybody is really important. But I completely agree. If I'd had a women's health physio come in and have a talk about incontinence issues and prolapse issues and all of it, it would have been amazing.
Yeah, even if I think just that you think, oh, like you say, because it's quite a signposting thing, isn't it? I'm forever sticking up for GPs. I'm like, look, they've got to know a little bit about a lot of things.
Yeah.
But I think some people still don't, I think they still think we give out pelvic floor exercises. So even if it's just that they remember that and think, oh, I know, there might be a women's health, pelvic health service. Oh, great. Thanks. That's given me a fantastic idea.
Brilliant.
So just before we dive, because I know, Lizzie, you're dying to dive into GSM. I just want to find out a little bit more about your role on the British Menopause Society, British Menopause Society Council. Have I got that right? It is the BMSC.
Yeah, so it's the Medical Advisory Council.
Yeah.
And my role within that, along with lots of others, is really around medical advice, medical guidance, answering colleague queries on the BMS website, but it's also overviewing lots of guidance that's coming out. So lots of documents, lots of advisory roles, really, and making sure that the advice that we're putting out both on our website, but also to the wider environment in terms of training is as up to date as possible. And you can imagine things change quite quickly. Some things change quite quickly, some things don't. So it's trying to get the most up-to-date information out as quickly as possible.
And the role of the council, so just for the listeners, the role of the council is that so the guidelines, so these are the NICE guidelines that are issued, they come from the BMS?
No, so the NICE guidelines are formulated by NHS England, essentially, and we obviously adhere to that as specialists. What we as the council members do is kind of assist and aid other organisations that might be creating their own guidelines, or if new guidelines come out. So the unscheduled bleeding guidelines came out a couple of years ago, thinking about how we adapt that to incorporate that into kind of further training and try and evidence base it as much as possible.
Okay. So then is the vision then to have menopause as standard then, do you think, at some point in medical training? Or do you think, can you not ever see, because you can't possibly, I suppose, include everything, can you? Do you see that ever happening, or do you think it will always stay sort of a little bit marginalized?
There has been huge amounts of inroads made, certainly in the last 5 years, as we all know. I mean, some would argue probably on social media too much, because it's just so much information out there. What do you believe? What don't you believe?
Yeah.
But certainly from a medical education perspective, things are definitely changing. We don't really have much to do with that. We can't really influence what medical schools do. We have to, we can offer advice. but really what they want to teach is what they want to teach. I mean, they have to cover certain things, like you say, and there's a
Yeah.
breadth of knowledge that people need to know. But
Yeah.
I think it is changing. And obviously the awareness is getting bigger, and there's more need. And certainly from a menopause education perspective, we've got a lot more people doing the menopause course on the BMS than we
Brilliant.
ever thought would happen. So
Yeah.
the desire for it is there.
Yeah, some of our local practice nurses are brilliant, actually. They are really, really good.
Mm.
So yeah, fab.
So for our listeners, if we take a step back then, can you explain, and Lizzie, can you say the word, please, GSM? What does GSM stand for? Because in the episode, I got so tongue-tied. I was like, what?
I know, yeah. It's just too long, isn't it? Genitourinary Syndrome of Menopause, isn't it? But that's why we all call it GSM, because it's far too long, isn't it, Claire?
It's a mouthful. I mean, it's better than what we used to call it, which was a vaginal atrophy, and that was just
Yeah.
like, a horrible word.
Oh, vaginal atrophy.
Yeah.
Yes.
I
So
mean,
can we explain, what is it then? Let's just take a step back, just for our listeners. What is it?
so GSM is sort of an umbrella term to describe lots of symptoms that happen around the pelvis during perimenopause and postmenopausally. And that can be a variety of symptoms, from very, very few to very severe, and there's a whole range in between. So we're thinking about, typically what we might talk about is vaginal dryness. So even discomfort putting on underwear, discomfort during intercourse, bleeding after sex, it might be leakage of urine, it might be recurrent urine infections. What we also know is it might be that the labia, the vulva, the external genitalia shrink back a little bit as the collagen is lost, because essentially this is being driven by a lack of estrogen or declining levels of estrogen. So there's a whole range of symptoms which will affect everybody differently, of course, and some women won't have very many and some women will have a lot. But we do know around sort of 80% of women will have some degree of GSM symptoms at some point in their kind of post-reproductive transition, that perimenopausal journey.
Yeah, and it's progressive, isn't it? So I think certainly that's what I found. And it's one of the, whereas I think a lot of things in systemic things often will level out, won't they, with a bit of time. But this, for me, it was horrible. I think it's possibly one of the worst things. I mean, it really.
Yeah, absolutely. So you're right. It's really progressive, and we know that. I mean, the sad thing is that so many women have significant symptoms and may not talk about it because it's still thought to be a bit of a taboo, or they have tried to talk about it and been sort of dismissed or not really taken seriously, so may never go back and talk about it again. And there's some really excellent treatments, which are life-changing treatments, quite significantly life-changing treatments in the form of estrogens, for example. And if you're someone that has recurrent urine infections, or indeed if you're an older woman who has what we call urosepsis, so gets significant infections from a urinary tract perspective, these can be so severe. These can be, the severe enough not only to put you into hospital, but to cause significant illness and even death. And so what we're thinking about is not just trying to put a plaster over the problem, it's treating the problem and treating it early so we stop those symptoms developing.
Yeah.
And do you find, just a quick question popped up into my mind, are you saying that does one symptom lead to another? So say if I'm in perimenopause, so a young woman in perimenopause, she starts to get some vaginal discomfort, i.e. itching, or there's some, she starts to feel a little bit uncomfortable, and then does that then lead on to other symptoms? So does the itchiness then cause the UTIs? Do you see a spiral with clients, with ladies, where it just kind of rolls and gets worse and worse?
It's really variable, I think. And like I said before, I think, what we know is that it will affect people differently. One of the commonest misunderstandings, I think, certainly from the people I see, is that their itchiness is thrush, so they keep treating for thrush. And actually it never really goes away. But what we've also got to remember is to keep our holistic hat on, and not everything is perimenopause. So is there anything else going on there? Do we need to be thinking about other conditions that can affect the vulva, the vagina, And that's when an examination is really helpful, because we don't want to miss, you know, GSM, but nor do we want to miss those other conditions that can mimic it.
Yeah, absolutely. Oh, Ruth, I've had a question then, and I thought, what was it? Oh, yeah, that was it. I've often had that thought, you know, I think about the care of the elderly ward upstairs, and I think, I wonder how many of the ladies up there, I wonder how, you know, I mean, obviously there's lots of different reasons that you can get urinary tract infections, but it does often cross my mind, I think, if this is more commonly prescribed, I wonder how much urosepsis you can prevent. I would just think, gosh, I wonder how we could work out what the percentage of those urosepsis patients are. You know, what percentage of them are due to just long-term vaginal atrophy? Because it is, you know, you're talking about, Ruth, you might not, well, you may or may not appreciate it, I don't know, but it's crazy urosepsis, especially in your older age, isn't it? Because it creates a massive amount of delirium. So you're then looking at, and also
I was just going to
delirium,
ask you to explain that for the listeners,
just
because
basically,
also
yeah.
up there. So just explain that a little bit more, Lizzie. So you'll see. So that's elderly.
Yeah, sorry, I've got
female.
an supply there, and my
They're not.
the elderly. Yeah, so you know, you do, so the urinary tract infections as you get older tend to become a little bit more serious, or travel a little bit further up, or in younger
Right.
as well. But so urosepsis is where it's not just a UTI, you know, it's starting to affect your bodily functions, your kidney functions, and it will cause delirium. So, you know, hallucination, you know, literally what it says on the tin, really. But that can, you know, people go off the feet. I mean, honestly, you just wouldn't believe it has such a huge effect. And so when I say off the feet, unable to mobilize, they're delirious, they don't know where they are, they can't feed themselves. And then it takes a long, long time, like months and months and months. If you look at the most recent sort of delirium data, it can take months and months for them to recover from that. So that will often be, honestly, like the difference between them having been relatively independent, needing minimal input at home,
Yeah.
all of a sudden being completely unmanageable. And because it takes so long to recover, and we haven't got time to give them, we haven't got the facilities to give them that time to recover, they'll often end up in homes. Well, if there were any homes, which is another entire conversation. But so it's quite, you know, it's quite serious. But as I said, there's lots of different reasons why you get UTIs, but it would just interest me. I think, I wonder how much of a contributory factor is the, like, just lack of management of things like GSM.
Yeah.
I digress.
Yeah, no, I agree. I completely agree. I think, you know, it would be great to be able to study that, wouldn't it? To be able to
Yeah.
put some research in the pipeline. And that, I know that there's various bits and bobs going on, certainly in residential homes and nursing homes. But if we could just sort of have that conversation, and a lot of these women wouldn't have ever had that conversation.
No.
Because we know the generational gap here is that lots of menopause symptoms, and certainly GSM symptoms, were never talked about.
No.
You did just get on with it. You certainly
Yeah.
didn't raise it as an issue. So, you know, there is a collection of women, I think, out there who probably would really would do well from having that conversation, but we sort of miss them in a way, which is a shame.
I mean, we see that in, you know, culturally in Wales, it's you know, not, it's just not was not spoken about.
Yes.
And I mean, and this is really what triggered the podcast for me, is when I spoke to a woman a couple of years ago, and she'd had double incontinence, and it was, you know, life changing. And then there was another client who, she was traveling, and she couldn't, she had to know where the toilets were in London. She could only go to certain areas. And then when you really start to look at the impact on women's lives, it's really quite significant, not just from an economic point of view, financial point of view, but, you know, my personal view is, I think that it's the trigger for a lot of ill health within women as they get older. So what you were talking about before, Lizzie, wouldn't surprise me at all if there's, you know, in 10 years down the line, when hopefully somebody's done some research in that, you know, the preventative care starts at 35. That's what I would like to see. Well, it's not even preventative care, isn't it? It's making a younger generation aware of the importance and asking the right questions of their own. So yeah, I hadn't thought of that at all, Lizzie.
No, yeah, often, and then I think, oh, maybe I've been a bit, you know, but I do think so. And but what I was going to say, you mentioned sort of culture, Claire, for you, I think what would interest me is, do you see cultural differences in presentation of this? Because obviously we're not overly multicultural. Well, we're getting better, aren't we, in North Wales?
Yeah.
And access, I think, to healthcare for different cultures is, again, another podcast. But being down in London, it's like, so you've got such a beautiful mix of cultures. Do you find that GSM presents differently within different cultures, or is there no difference? Because I know menopause does present a bit differently, doesn't it?
Yeah, it does. I don't think it does necessarily. I think how we talk about it and how different cultures talk about it is certainly very, very different. And
So,
one of the difficulties we find is, if people don't speak English, having a translator within the consultations can be, of course, helpful, but we don't always get the like for like translation for that. So I'm very mindful of being very honest and answering, what is your vaginal health like? Do you have vaginal dryness? Do you have pain during sex? Thinking about those words as they can't be misconstrued, but they also can't always be translated.
no, I was going to
Depending on the
say,
translator, so if it's a male translator, it for certain cultures, it's difficult to kind of directly translate that.
yeah,
Um, so that's a real difficulty. And again, like if you get it wrong the first time and you don't have that honest, open conversation, we've got lots of evidence to say that person might never come back and talk about that issue again. And
yeah,
so that ship has sailed, which is a real shame. And then what we've got, certainly in London, is your cohort of survivors of FGM, so female genital mutilation.
Yes.
yeah,
And so we know that obviously they experience GSM symptoms differently.
Mm.
okay,
And it's really important that we talk about that as quickly and as early as possible, because as we know, there's various different forms of FGM,
yeah,
but they will all have an impact on our vulval vaginal health and our pelvic floor as we
Mm.
progress through the menopause. Um,
mm,
and early treatment or some sort of treatment that doesn't necessarily have to be hormones, but some sort of treatment is vital. So again, there's that cohort of patients, certainly in London, that we see. Again, it's really difficult to have those conversations, and often it's
mm,
about building lots and lots of rapport. You'll know this, Lizzie, just building rapport, making people feel comfortable, making people understand who you are and what you're doing and why you're asking these questions.
Mm.
And that
mm,
takes time.
Mm.
yeah. So I'd be interested actually to know a little bit more about that, because I haven't had in the 10, 15 years that I've specialised in pelvic health, because we're up in North Wales, nobody as yet has presented to me with any kind of like FGM. So it's something that I'm aware of, obviously, definitely. And I know it is in North Wales, absolutely. But yes, I'd be interested to know a little bit more about how they present differently with GSM.
Well, often it's a lot more severe. So
Yeah.
if they've had certain procedures, so for example, if they've had clitoral removal or labia
Mm.
removal, we can see quite significant dryness quite early on in perimenopause. But you've also got to remember, and again, I don't want to generalize here at all, but these are women that have dealt with a lot of discomfort
Mm.
and
Yes.
some of them have dealt with a lot of discomfort during childbirth as well.
Mm.
So they're almost accepting of it in a way,
Mm.
and because culturally it can be, this is part of the culture. Again, it's not talked about, so it might not present, you might not see it.
Mm.
I guess one of the things that we always look out for, certainly where I am, is women coming for smears and making sure that when we're having when someone's having a smear test, that vulval vaginal health is really, really accurately examined,
Mm.
Yeah.
and
Yeah.
that we signpost correctly immediately.
Yeah.
Um, and I think awareness training is really important for that. I mean, essentially the symptoms are very much the same, but they can be severe. So it is, on that spectrum of really, really painful sex, really
Yeah.
bleeding after sex a lot more, which obviously gives
Oh,
you those red flag symptoms. You worry about other things, don't you, if you
Yeah.
yeah.
have those.
Yeah.
But dryness, soreness, cracked skin, bleeding skin,
Yeah.
that tends to be what we see a lot of.
And do they present later? So if they're used to, so I'm fascinated by this now. If they, if these sort of ladies are used to pain, do you find maybe they present a bit later or not particularly because they can tolerate it a little bit
Yeah.
more?
Yeah, so often it's, they've had bleeding for some time,
Yeah.
or um they are so uncomfortable with intercourse that, there's they have to do something.
Yeah.
Yeah.
But I wonder just how many we're not seeing.
Yeah.
Oh, the most I know it's in North, absolutely.
It's probably huge. It's a huge number.
Yeah.
It's you just, I mean, you said the phrase accepting it. Get
Mm.
on with it. I mean, how many women, and I still hear that, every morning when I go swimming in the local leisure centre, there's a group of older ladies and they're wonderful, but they're just, and I'll say, oh, I'm doing the podcast tonight, and then they'll be like, oh well, we just got on with it, as they're slapping their tenor lady onto get as they're getting dressed. So in terms of, because I'm just conscious of time, Lizzie and Claire, in terms of public awareness of menopause and GSM, have you seen, is it because London is obviously, what happens in London, the rest of the country catches up, a lot quicker. I mean, it's different now, social media, but are you seeing, is it getting better, Claire?
Yeah, I think it is. I think we've had a lot of negativity around kind of, oh, more needs to be done, more needs to be done. Of course, that's the case with everything. And don't get me wrong, menopause, women's health is up there on more needs to be done. But we are doing so much better. I think that compared to how things were a few years ago, the awareness obviously is much better amongst everybody. And the awareness is improving amongst healthcare professionals, importantly, too. So we know that there's an over 40 women's health check that the NHS has instituted. So hopefully what we're doing and what we're seeing now is more people being asked about perimenopause symptoms
Yeah.
from an earlier age, or at least empowering women to think about it from an earlier age.
Have we got that health check in Wales, Lizzie?
Actually, I don't know.
I don't think we have we? We just need to double check that and then put it in the notes, because yeah, I don't think we've got the. I think it's NHS England, but we don't have. I don't think we have it in. I don't think we have it in Wales. So we've got a few, because I mean, I know you guys can probably talk all evening about this, and we'd love to do a more in-depth discussion with you, Claire, at a later date. But we've got a few questions, Lizzie, that a couple of our listeners have asked, and maybe some of them we just touch on them tonight, because I know one's going to touch on the on estrogen. So do you want to just go through a few of the key questions?
Yeah, absolutely. I'm just trying to choose the best ones, actually. So here's a good one. Because actually this is something that's popped up in clinic recently. Since the menopause, I find that my clitoris is just not as sensitive as it used to be. It's actually really hard to climax. Is this common? And is there anything that I can do?
Yeah, this is a really, really common one. And part of the problem is that we know estrogen and estrogen receptors are huge in the pelvic floor, and certainly around the clitoris, where all the nerve endings are. As those levels decline and as we lose that estrogen, what we find is that we're less sensitive and we lose that sensitivity a little bit. And again, this is a spectrum. Not every woman will have it to the same extent as someone else, but some really do experience significant discomfort and also difficulty climaxing. What we aim to do is it's most certainly not a lost cause. So please speak to somebody about it, because actually the treatments that we use are generally vaginal estrogens as first line. They are not HRT. They're really, really safe, and there's very few women who can't use them. And actually using that internally and externally, so as a cream that's internal and external and certainly placed around the clitoris, can be really helpful. The other thing, and Lizzie, you'll know about this, and you'll probably be able to talk about it much better than I can, is trying to increase the blood supply. that area. And the way we
Yeah.
do that is vibration. So can you use a vibrator? Can you use something? Can you use self-massage that increases the blood supply, gets the blood flowing? And actually that also can be really helpful too.
Yeah, brilliant.
That's a really good tip.
Yeah, it is. Yeah, we were going to do gadgets and gizmos episode at some point.
Yeah, I'm looking forward to the gadgets and gizmos.
Yeah, yeah.
I've got
get a bit of research done. Right, next question. What about oh, I know. This is a good one because this is on the vaginal estrogen one. Where's it gone? What about ladies that don't want to or can't take topical estrogen? They are few and far between, but what options do they have?
So I'd say the women that really can't use topical vaginal estrogen are the ones that potentially are on aromatase inhibitors for breast cancer. There are very few women, aside from those who really can't use vaginal estrogen. Obviously, it's a case-by-case discussion with your doctor. I would make sure that you've seen a menopause specialist, because ideally, if you can't, many women can use vaginal estrogen, but see a specialist because it might be that you really shouldn't. The next step would be lots of different lubrication and lots of vagina moisturizers. So in the same way that we moisturize our face, we should be moisturizing our vulvas and vagina. And there's lots of different products on the market. The ones I typically use are the Yes moisturizers. You can get free samples from them. Sutil is also really good. It's a nice lubricant that has
my little bag of Yes.
Got your bag of Yes. What you want to be doing is trying to use a lubricant or a moisturizer that doesn't contain too much glycerol. Glycerol can be quite irritant to the skin and can also cause a bit of thrush. So the predominant thing I'd say is get some Yes. They come with moisturizers and lubricants, and they are fantastic, and you can wash with them. That's the other thing. Don't wash with anything other than water or other than Yes moisturizer as well. So no soaps, no Lush bath bombs, no shower gels, no shampoos, just warm water. And that will also make a big difference.
And is Yes readily available? I need to check this. Is this readily available in Boots and online? Yes.
It is.
Have Boots got an alternative? Is there an alternative as well to Yes? Or
yeah, so there's Sutil, and there's also Dr. Wolf, WOOLF, I think it is. And there's also Replens. Replens is another really good one, which is a lubricant rather than a moisturizer.
Right.
And that's also really helpful. But I think try Yes first, because Yes you can get some free samples of and give it a go.
Right. Okay. I'll actually send them this podcast to get in touch with them. No, I think this is that's a really useful point for the listeners, and we are just about to launch our community, and we do want to do some ongoing educational stuff. So things like that will create a download and reference, and it's good to reference 2 or 3 different products of different price points as well. We're keen to do that as well. Have we got time for one more question? I'm just conscious of time.
This is right. Okay. So actually I think we've answered that one. Oh, I know. This is a bit more of a general one actually, but I think it's quite important to get out there. So, so for anyone that wants any independent advice, there's the women's health concern, isn't there? Can you tell us a little bit more about, or tell the listeners a bit more about that and how they can find it? That was my
Yeah, absolutely. So the Women's Health Concern is the patient arm of the British Menopause Society, and they have lots of brilliant evidence-based information on their website, lots of videos, leaflets, patient information leaflets. And they've also got a forum on there as well, so you can ask questions. It's a really useful and useful tool, but the beauty of it is that you can dip in and out of it and find bits of information that is all really evidence-based, and that's the key. I know that there is so much information out there. You can go down a rabbit hole of what do I believe and what don't I believe. I think the Women's Health Concern is a really trusted site, as is Menopause Support. That's another really, really trusted site, and there's lots of great information on both of those.
Okay, brilliant.
Okay, I'm going to go back and edit all the show notes and put those 2 links in our previous episodes as well on YouTube and on Facebook. So we've got those links. links below. Anything else, Lizzie, on your list?
Oh,
Because I'm just conscious
there's
we've taken
so
up,
much.
we've gone over what we've gone
No,
over.
actually, I would love it, Claire, if you you know, see how you feel after it. I would love to get you back on and talk about. There's so much I want to ask, and so much like you're obviously a mine of information. And maybe next time kind of do the more on the systemic HRT, and that would be brilliant. I've got loads of questions. I could talk to you all day, frankly.
You know where I am. Just get in touch. Absolutely.
Brilliant.
Excellent, excellent. Thank you so much.
Yeah, that was brilliant.
For
Thanks,
Claire. This evening. That's so informative. So listeners, thank you. I hope you've enjoyed this special episode. We will hopefully be hearing from Claire again soon. Thank you, and enjoy your evening, day, whatever you're doing. And remember, if you've got any concerns, what's our message, ladies? Who's going to give up? Lizzie, what's the message if our ladies got any concerns about their pelvic floor health?
Go straight to your GP. Straight to your GP. There's help out there. Definitely. Don't suffer in silence.
Don't suffer in silence. Thank you.
Oh, thanks, Claire.
Thank you, Claire.